Bates. I'm with the Poverty Action Lab at MIT. And what I'm going to do for the next talk is a little bit different from most of the talks today, in that I'm not presenting the results of an evaluation, but rather giving you a little bit of an update on a new regional office that we started that's focusing on the North America region, and a healthcare delivery initiative that we're doing to encourage more randomized evaluations in this area. So let me just give you a brief overview of what I'll discuss. As I mentioned, we'll talk a little bit about the Poverty Action Lab. I'll give you a background on who we are and what we do. I'll give you an example of an RCT that some of our affiliates are conducting right now with the Camden Coalition of Healthcare Providers that might be interesting to you, and then describe some of the resources that we provide for the research community at large who are interested in using the approach of randomized evaluations more generally. So about JPAL, the Poverty Action Lab is a network of independent affiliated professors who all pursue their own research agendas, but are united by their approach of using randomized evaluations or randomized controlled trials to test important policy questions. And the lab was founded at MIT in the Department of Economics about 11 years ago by Abhijit Banerjee, Esther Duflo, and Sentel, and now includes 111 affiliates around the world. As you can see in this map, our affiliates have a wide range of topic areas that they do these experiments on. So in addition to health, agriculture, education, environment and energy, finance, microfinance, labor markets, political economy, and governance. And for most of JPAL's history, a large focus has been on international development. So we have some well-known studies in Kenya and India, looking at a variety of policy questions. You can see our affiliates have over 560 ongoing and completed evaluations across 61 countries. Over time, JPAL opened up regional offices at different research centers around the world. So we've had JPAL Africa, for instance, JPAL South Asia, JPAL Europe, and the most recent one is JPAL North America, which opened last year. And we were very fortunate to have Amy Finkelstein at MIT and Larry Katz at Harvard join the network, and they serve as the scientific co-directors of the North America Regional Office. So I've worked at JPAL for the last 4 years approximately. I was previously on the JPAL Global side working in our policy group in international development, and then moved over to the North America office when we launched that. So what we do is basically 3 main activities. One is evaluation. So this is the research that our affiliated professors conduct. RCTs on a variety of topic areas. We also do policy outreach and capacity building. So we conduct trainings to help people understand the value of evidence, to help them understand how to implement randomized evaluations. And we also conduct policy outreach. And some of that is summarizing the results of completed evaluations in an accessible and salient way. We also build relationships with governments and decision makers around the world to help them understand the evidence. So for the North America office, our affiliates are conducting research on a wide variety of topics based on their research interests. One area that we are focusing on initially is the area of healthcare delivery, and we've launched a research initiative in that realm. And the idea is to encourage more RCTs of interventions that have the potential to improve the efficiency or effectiveness of healthcare delivery, very, very broadly defined. So this initiative is led by Amy Finkelstein. I'll explain a little bit more about how we do that and what our initiatives look like later, but I'd like to give an example of an ongoing RCT that Amy and others, these collaborators are doing right now, because I think it's a nice illustration of the kind of work that we're hoping to encourage. So this is an RCT of the Camden Coalition of Healthcare Providers Hotspotting Care Management Program in Camden, New Jersey. The program is called Link to Care, and this is considered a very promising approach to working with some of the highest cost patients. Dr. Jeff Brenner has been profiled in The New Yorker in an article by Atul Gawande a couple of years ago about the hotspotters, and this has gotten a lot of attention nationally for their approach. And basically the idea is that they target not based on one particular condition, but along the idea that people, they target what they're defining as superutilizers. So people who have had 2 or more hospital admissions in the last 6 months, along with multiple chronic conditions. And this population, you can think of them as being less than 2% of Camden's population, but account for more than 1/4 of the hospital spending in Camden. So think of people who have a lot of complex care needs and are driving a lot of the hospital spending. And the overall goal is to improve the patient's self-sufficiency and navigating the health care system and broader support systems that they could get support from. And what the Camden's approach is that they have a team of nurses, of healthcare workers, of community health coaches who meet these patients at the hospital when they're admitted and then provide a comprehensive wraparound set of services over at least a month and on average about 3 months. So I'll talk a little bit more about what the intervention is in a moment. I think one thing that's worth highlighting is really inspiring to us is that Jeff Brenner, the doctor who has designed this program and who runs it, has gotten a lot of attention for this. He recently received a MacArthur Genius Grant for it. Like I said, a lot of national attention for it. He volunteered to do this RCT in collaboration with the researchers here. And that's, from our perspective, this is exactly the kind of collaboration that we hope to encourage, and I'm personally very inspired by his leadership and putting himself out there and being public about the fact that they're doing this RCT long before the results are known. So what does the actual program look like? It starts with a data system, the health information exchange that they set up across Camden that provides a daily feed of patients as they come into the hospital. When someone is flagged as a superutilizer, meaning 2 or more visits in the last 6 months and a number of other conditions, the team will meet them in the hospital and begin the engagement with the patient. Now, prior to the RCT, they were capacity constrained on how many people they could serve, and whether they reached out to a patient at any given time was fairly ad hoc in the sense that it depended on whether they had capacity at the time when people were in the hospital, and so some people were in the program or not. With the RCT component, the randomization is determining who receives the program and who doesn't, but overall the same number of people are being treated. So they engage the patient at the bedside and explain to them that this is a program that they can access and explain how it works and also get their consent to be a part of the trial. And if they consent, then the randomization takes place. And after patients go home again, there are a number of home visits that happen over the course of the engagement with the patient. One concrete example, to give you a sense of the kinds of things that they do, is home-based medication reconciliation. So actually going into the home of the patient and saying, let's look at all the medications that you've accumulated. People tend to not throw away. Even old medications, it can become very hard for people to navigate and know which medications am I supposed to take today, which ones do I need to get refilled, and so it can be very overwhelming for people who are going through quite challenging periods in their life. So this is an example of before and after, right? Lots of confusing medications that people need to navigate, and then an organized system with pill boxes afterwards. So one way to think about this is that the intervention is trying to help people get over that initial hurdle of managing what seems like an unmanageable problem of all these conflicting disorganized medications. The other thing that they do is they accompany the patients to lots of different visits. So one example would be the first visit with a primary care provider. The goal of the intervention being to link people with ongoing services even after the 1 to 3 months that they're engaging with the Camden Coalition, so they can have an ongoing relationship. And so the team, the health coaches and the nurses who care for this individual patient will actually help them schedule the visit, ensure the cell phone is working so they can schedule the visit, accompany them to the health visit, and be their advocate in that sense. And in addition to helping them overcome the barrier of these first visits, it's also, they also provide a lot of practical help in enrolling for different social services. So helping patients find the documents that they need to enroll for a variety of services such as housing or other services that might be helpful to them, and removing the barriers that exist in that regard. The outcomes that the team will be looking at, so this study was piloted in the spring. Currently they have about 100 patients enrolled. It's been ongoing since this summer. The outcomes that they're hoping to look at are overall hospital readmissions, healthcare use, emergency department visits, primary care, specialty care, and additionally use of social services and economic outcomes. So the other piece that I want to touch on is how we work more broadly, and I'm happy to answer any questions about this as well. One of the things that JPAL has done for many years on the international development side, and which we're doing now domestically as well, is to serve as a matchmaking function between organizations like Jeff Brenner or government entities who would like to have an evaluation done of their program and academics who are interested. And so we have staff who work in different program areas who can either provide this on an ongoing basis as people call in and say, hi, I'm really interested in finding a researcher who might be interested in this particular question. And then the staff can ask some screening questions and figure out, is there an appropriate sample size? Does it look like it would be feasible to conduct a good evaluation? What's the data that are available? And sometimes we also host targeted events that bring people together and on both sides, implementers and researchers, to meet and develop new collaborative ideas for research. And this is motivated, one thing that I find interesting listening to Amy describe her experiences after conducting the Oregon health insurance experiment, is that when, from the outside, for people looking for academics to conduct studies, it can be sort of non-transparent what people are interested in and who might have capacity to take on new projects. So after the Oregon health insurance experiment was publicized, she got a number of calls from different states and people saying, oh, we're also randomizing something. Would you be interested in looking at this, right? And so she takes the first few calls and then you realize, oh, when we said we're randomizing, we're actually talking about random sampling as opposed to randomly assigning something. And there are a lot of things like that that I'm sure as many of you as academics can appreciate it becomes difficult to take those calls and then you're not sure which of my colleagues might be interested in. And so JPAL as an organization tries to smooth that process and help match people up. JPAL, our partner organization, Innovations for Poverty Action as well, have built up a lot of research resources over the years on some fairly simple things like protocols for randomization or data collection or setting up a project, trainings for RAs on everything from data coding tips to different aspects of running a randomized evaluation. So this is something that we're increasingly trying to make publicly available and share with the community. And we also, as I mentioned, try to share results and make it accessible. So you can see here a screenshot of the database on our website where people can search by region or by topic area or by researcher to see what evaluations have been conducted. And we also summarize results. So this is a 4-page brief here on the Oregon health insurance experiment, for example, that attempts to distill 4 different academic papers into 4 pages with some accessible graphs. So that's part of what we do in that regard. But I'll end now. I know we're at time, but if you have any questions, feel free to be in touch, and I'm happy to answer any questions now as well.